Hi. You're muted.
You muted me when you set it up.
Oh.
How many people you got getting on today, you think?
About 28.
Oh, that's great.
Yeah.
All right, I may just leave my picture up there and stay on for a bit and listen.
I'm actually gonna turn off the video for me once she starts and once Linda starts introducing her.
Okay, and so let me ask you a quick question. So when you invite someone to be a panelist,
Uh-huh.
basically they have to log in with that special link that you send
Right.
them
Right.
versus the generic.
Right.
Is that how that works?
Yeah.
That's what I thought. Okay, I'm just going to leave it on so I can listen.
Okay, cool.
Thanks.
Hi, Linda. Linda, you're actually muted now. Let me see if I can, I can unmute you. Okay.
Okay. You still say Ellen Appler. Do you know that you can actually change that?
Well, I don't want to because this is her account.
Okay.
No, you can, Jen.
Yeah.
All you're doing is changing the name here.
Okay.
Just click, left click on the name and change it to Jennifer Bernstein.
Okay.
It's putting it there by default, but you're not
Gotcha.
changing it permanently if you change it.
Okay.
So where it says rename, just
Gotcha.
rename it. There you go.
Okay.
Get the lighting right.
I didn't know if it did that permanently or not. So perfect.
No, and if it did, I'd just change it back.
Okay.
Okay. All right, I gotta go grab a phone call, but Linda, good luck today.
Thank you.
I'm sure it'll go fine. Pardon?
What's that?
Am I still muted?
No, you're not.
Oh,
I'm gonna
okay.
stay on and listen, but I'm gonna mute mine.
I'm going to end up afterwards, obviously. I'll mute. And I may, if I need to get a call, I may just get rid of my picture.
I'm going to do that too because I'm going to live tweet. So I don't want to look like I'm,
Right. That because when they took the picture of everybody, most of the time I was looking up so that it would look like I was looking up.
Right.
And then the one that I wasn't, I was reading something. So
Right.
Yeah. I kept getting texts from people who were watching. So it was the last one, everybody seemed to really love.
Yeah, I think so.
And she looks great.
I think it's going to be a great discussion.
Okay. I have trouble knowing where to look. God, I look at my hair. I cut my bangs, but I cut it too short.
Oh, that looks cute. Your hair looks very cute.
Thanks. I don't know. It's weird. It's a little long. It's not that it's gotten so long. It's just that the layers have all grown out and it's weighted, and I'm just sort of. But I don't color my hair, so it hasn't changed colors. But I do have a lot of. You can't see it. I have a lot of gray sprinkled all over.
Really?
Yeah. It just hasn't. I said I'm going to turn gray by the end of this.
Yeah. Wow, you don't have any grays usually though?
No, I don't color. I haven't colored hair. So I made an appointment for for a month from now.
Yeah.
So, and it'll be since February 4th. So it'll be like, a long time, 4 months.
Yeah.
So, yeah.
Okay, well, hopefully Dr. Thompson will be here soon.
Yeah. I got on early and I didn't know.
Yeah.
I really wish I didn't see this. Okay. So I have it written out. Putting it in front of us.
And I'm going to make her a co-host.
Yeah.
When she gets on. And I can, because then she can share her her screen.
Okay. That'll be good.
Yeah.
Oh, here she is. Hi.
Hi, Dr. Thompson.
I think she's still.
Hi, Dr. Thompson.
Hi, Dr. Thompson.
I'm going to go ahead and make you a co-host.
Okay.
So if you want to share your screen, you can do that.
Thank you.
You're welcome. Thank you so much for for presenting today. We are so excited to have you.
Oh, you are very welcome. Hopefully, I will be able to provide the information that you wanted for the group.
Oh, I'm sure you will.
Sure, it'll be great. I'm gonna silence my phone.
Oops, wait.
Just gonna put it on silent for a second.
As we still haven't hit that 12 o'clock hour, I am going to share my screen and then I will move into the discussion. Can let me know if you, when you see, let's see, there it goes. You should be able to see my slides now.
Yes.
Great, I'm going to go ahead and get started. So thank you for that wonderful introduction, and that means I can progress from this first slide, but I do want to sort of orient you to what I want to do this morning. First, thank you for inviting me to speak about African American maternal health in the context of COVID-19. So much of what I've been doing over the last 2 months has been COVID-19 related. And I think what this pandemic has sort of illustrated is what those of us who study disparities, including health disparities, have known for some time. And that is the context of a racialized society makes the African American community and other ethnic and marginalized communities vulnerable, regardless of what type of social shock we experience. We saw this in the 2008 recession, where outcomes in terms of health and economics hit harder in the very same communities that we are discussing for COVID-19, and recovery was slower. And so it was not unanticipated that the same thing would happen with a major health concern or crisis such as COVID-19. I want to start by also saying that the medical and research community knows very little about this virus. And so all of us in our discussions have agreed that the best answer for any number of situations is we honestly do not know. We know very little about this virus, so we know very little about how it affects pregnancy, maternal health, but we can predict a great deal about how it has and will impact disparities. For that reason, I'm going to talk about maternal health disparities first, because I think that sets the context. You have to know where we were prior to COVID to understand where we are now. And then I'm going to talk about what we know about the impact of other SARS viruses on pregnancy and maternal health, because that's where we take our cues and try to understand how this will exacerbate the disparities that we already see. And then I'm going to go into what has been observed so far and what's recommended and what people are doing to attempt to avoid any further exacerbation of maternal health disparities, and particularly those related to the COVID virus. And so I'm going to walk you through a series of CDC slides where we begin to explore the maternal health disparities that exist. And it really has been interesting to me. We have been looking at a range of health disparities for decades now. And one that has always been of concern are the infant mortality rate and maternal mortality rates. Infant mortality rates come into play because they are considered the most sensitive measures of the health of a nation and the well-being of a nation. And those statistics, like the maternal health disparity statistics, have been stubbornly consistent, with the same groups represented as having higher rates of death. we talked a lot about that infant mortality rate. We paid a little less attention to maternal mortality and health disparities until several very prominent African-American women came forward with their stories. And probably the one that received the most attention was when Serena Williams gave birth and then had significant health complications that were avoidable, that put her at risk of being one of those statistics, and she was willing to come forward and discuss her situation. And that put this issue on the radar of many people who wouldn't have thought about it otherwise. And so on this first slide, it really lays out the data that shows that you have significantly higher pregnancy-related mortality ratios for Black and American Indian, Alaska Native women. I put this slide in because it's not just Black women, it's also our AIAN community. However, you will notice that consistently, the rate of Black maternal death is higher than it is even for the American Indian, Alaska Native community. And so the data run from 2007 to 2007, 2008 to 2015, 2016. About 700 women die a year of pregnancy-related complications. Native and African-American women, clearly, as you can see by the graph, are about 2 to 3 times more likely to die than white women. These disparities are persistent, and they have not changed significantly in the time period being observed. And we have some later data, but these trends are not shifting. And this has been a fairly stubborn problem. Pregnancy-related mortality rates increased from 15 to 17 pregnancy-related deaths per 100,000 births over this time period. And most of this is accounted for by these two groups. And to make it clearer, think about that 15 to 17 per 100,000 number, and think about the fact that for African-American women, that number is 40.8 per 100,000. And for Native women, it is 29.7. For white women, it's actually 12.7, and for Asian Pacific Islander women, 13.5, and for Hispanic women, 11.5. So you see a very dramatic difference here. Now, I always share with people the fact that we see health disparities in all the areas that we see in the US and other countries that have racial and ethnic minorities. But the disparity rates tend to be a lot narrower than we see in the US. And so that's always a red flag. Why, when we see these same types of disparities in other places, they are heightened here? And this is one of the issues that lead us to talk about them in a little different way than some people might expect. So your first thought would be it's something biological. What's wrong biologically? Or perhaps it's access to healthcare. There's some of that, but those other data in terms of what we see in other countries lead us to look at other factors that may be driving this in the US. But disparities are worldwide. I said all of that just to say disparities are worldwide, and they're problematic worldwide. But we have specific factors that we have to call out and pay attention to. It's also worth knowing that in this time period, we failed to meet our Healthy People 2020 goals for maternal health and well-being, and we failed to meet the World Health Organization goals. And with respect to the World Health Organization goals, there were other countries who were able to meet those goals, and we did not. So this slide basically says the same thing I just said, but it brings into focus the disparities as it relates to age. And so what we know is as women get older, the disparity in maternal health outcomes increases. And I'll show you that slide in a minute. We know some of the causes of these maternal deaths. Some of it has to do with cardiology problems. Some of it is pulmonary embolism. Hypertensive disorders of pregnancy contribute to more of the pregnancy-related deaths among Black women than among white women, where hemorrhage and hypertensive disorders of pregnancy contribute more to the pregnancy-related deaths among American Indian and Alaska Native. Now, when I say more, that doesn't mean that both groups aren't experiencing all of those other complications, but those are some of the issues that we know women contribute to women's deaths following pregnancy. But when I mention those issues, it probably occurs to you that these are health issues that, if they're identified early enough and are treated appropriately, women should not die. And that's what makes this all very concerning. So on this slide, you can see that the inequities that I'm discussing increase by age. So you can see that by the time a woman is in that over 35 to over 40 age, we see a really significant increase in the maternal health outcomes disparity ratio. So it's 1.5 among women who are 20 years or less of age. And by the time they're 30 to 34 years of age, it's about 4.3. But some people would argue that, well, if it's not biological, the basis for these disparities, perhaps it's because these women, African-American women, may be less well educated, may have lower health literacy, may not understand or be able to take care of themselves as well because of these factors. Perhaps they don't have access to health care. We know that the insurance rate in the African-American community is lower than the insurance rate in the white community. And access to health care is definitely a problem in the American Indian and Alaska Native community. And so we have to factor those issues in. We also know that maybe women will have difficulty getting to healthcare appointments, prenatal appointments. We have to factor those things in. But there are some aspects of the data that caution us that this can't be the full explanation. One of the things that we've noted is that there are still significant disparities among women with higher levels of education. So you would expect that if this was about access to insurance, about health literacy, about the ability to understand and comprehend doctors' instructions, that as women attain greater education, the disparities among women would diminish. And in fact, while they may lessen, we see substantial disparities even among very well-educated women. And we also see substantial disparities among women who have sufficient income to access health care and also are insured. I always add this into my presentations when I talk about maternal health outcomes because of my own pregnancy-related experiences. I made it very clear to my physician when I had my first child that I was Rh negative. And yet somehow she neglected to inform me of when I should have had a RhoGAM shot. And when another doctor queried me about it and made it clear that this should have already happened, and I talked with her, her explanation to me was quite startling. What she shared with me was that her assumption was that most African Americans are not Rh negative, and so I wasn't Rh negative. Now, I had told her I had my blood tested. I knew my Rh status. It's important for a woman who's pregnant to know her Rh status. And I communicated that to her, in addition to which it was in my chart, which is how the other physician knew that this was my status and instructed me on what was supposed to happen. But it was that bias. First, it was a decision that I wasn't capable of having this information or knowing this information and relaying it to her, and she dismissed it. It also pointed to a failure to consult the chart. If she had any questions, you would have expected that chart consultation. But that didn't happen. And that can have significant impact. Now, the reason I relay that story is because as people have explored why we have been unable to address these maternal health disparities, in the qualitative component of this literature, these stories emerge time and time again, where women are communicating health concerns. They are letting physicians and nurses know that there are things that are important to their pregnancy outcomes that they should attend to. When they start to feel symptomatic, they are communicating this, and that in many of these cases, those communications go with little response and very little attention. And this is one of the factors that seems to throw these women into crisis. And so these findings, all of these findings start to come together to suggest this, that the disparities that are observed in pregnancy-related deaths for African American and American Indian, Alaska Native women is a complex problem. It's a problem of health status because we do know African Americans have a number of premorbid conditions that complicate pregnancy. But we also know that those factors alone are not accounting for the outcomes that we're seeing. There are social issues that I've mentioned, and I'll talk about more, but there are also some biases and issues in the healthcare delivery system that have to be addressed as well. So as I was mentioning, these disparities by education level, and you can see that Black women with at least a college degree were 5 times as likely to experience a pregnancy-related mortality as women with white women with a similar education. So you don't see that disparity lessening necessarily just because women obtain greater degree of education. You'll also notice on this slide one thing that I did want to point out, and that the one point at which the American Indian, Alaska Native pregnancy-related mortality rate is higher than that of Black women is when individuals have less than a high school education. So one of the things that we have to think about is what would need to happen to improve mortality rates for African American women even before we are challenged by something like COVID. Now, one of the things that's been discussed and everyone thinks would help improve the situation was the implementation of standardized protocols in quality improvement initiatives, especially among facilities that serve disproportionately affected communities. And so having standardized checklists, post-delivery, checking women for any signs or symptoms that would suggest that there might be clotting, that there might be hemorrhaging, that there might be hypertensive reactions that will put that mother at risk. With clear instructions to those patients at discharge of signs and symptoms to look for and to report, and actions and steps to take should they have any of those experiences. There also have been efforts to develop pregnancy-related death review, mortality review panels in every state, because what some states that are doing better in managing and driving down maternal pregnancy-related mortality rates is that with these review panels, they can gather all of the data on patients who have experienced complications as well as death, and they can understand what were the factors, which hospitals, what are the protocols in those hospitals, are patients receiving standard of care, and then what steps do they need to take in particular facilities for particular patient populations, and then what treatments, what interventions seem to be most effective in reducing risk to individual women. But the second factor is one that I've alluded to, and that's identifying and addressing implicit bias in healthcare that would likely improve patient-provider interactions, health communication, and health outcomes. And this is one of the areas that I have studied. And what I do want to say here is that when we talk about this area, people's minds often go to physicians. And the story that I shared was a physician's story. But in my own research and some of the qualitative narratives, what is also present is not just physicians, it's the healthcare system. And so it involves nurses, and everyone who is caring for that patient, and people being willing to listen to women when they have complaints and when they raise concerns. And that doesn't always happen. But no one wants to assert that this is necessarily because people are racist. But what we do know is implicit bias operates. And what I mean by implicit bias is that we all come to every situation with a certain set of assumptions that operate outside of our awareness about and with reference to other people. And there are a number of these that have been identified in the healthcare system, one of which is related to pain and the expression of pain. Some of it is related to, because people often believe that members of the African-American community can tolerate high levels of pain. When people are expressing that they are in distress and in pain, sometimes that's ignored because the perception is that, one, you can tolerate it. And it's interesting because this is one you would think that today, if you, given everything we know and how much we talk about these disparities, when you survey medical students and residents, you would not see responses similar to what we saw a decade ago. So, but what we know from some studies, when you ask people, do you think African Americans have a higher tolerance of pain? Medical students and residents today will still endorse that as true. And that has no bearing in biology, fact, or anything else. And still you get endorsement of that. We also know that prescribing practices can be influenced by perceptions that are implicit, not explicit. People aren't deliberately trying to hurt someone, but if the perception is you can't afford a particular procedure because you're an African American and you're less likely to be insured, rather than establishing that in fact you don't have the insurance, you don't have the wherewithal to pay for that intervention or treatment, or you don't have the capacity to understand a set of instructions or to recognize a set of symptoms or circumstances. And so sometimes that information will not be relayed, or will not be relayed in a way that's designed to assist in you fully comprehending and implementing whatever instructions would be required. So when women aren't given the information that they need because people assume they can't understand, and or that information isn't even shared with their family members, but again, because there's an assumption that you will not comprehend or understand, or treatments aren't offered or considered that would be standard of care for members of other communities, because an assumption is made you lack insurance and you cannot pay for that. All of those things begin to compound and contribute to some of these negative outcomes. But embedded in that is, if you understand the health status of a particular segment of the population, you should be cued to look for and monitor for certain situations and outcomes more intensely than you would in other communities. And since we know hypertension, diabetes, and obesity are experienced among African American women at higher rates, you would expect that medical professionals who are attending to women who are pregnant or who have recently given birth would be monitoring for any signs or symptoms that those comorbid conditions would result in some maternal distress or complication following birth. And what we find is that's not always the case. Some of that may be related to the facilities where women are receiving their care and giving birth. So one of the characteristics there that we are aware of is the fact that physicians working in predominantly racial and ethnic communities are less likely to be board certified. And you are less likely to see standard of care. And so that's another reason for that recommendation for more standardized protocols and quality improvement initiatives, particularly in those facilities, in those communities. And I think I've given you enough of a sense of this issue. And so we can move to COVID-19. Now, from everything that is known at this point about this virus, pregnant women appear to have the same risk for COVID-19 as adults who are not pregnant, but a great deal is unknown. But we do know that pregnant women have had a higher risk of severe illness when infected with viruses that are similar to COVID-19. So that if they're infected with SARS, when they were infected with SARS, MERS, or when they've had other viral respiratory infections like influenza, they have had severe illness. So given that you know this, the recommendation would be for pregnant women, along with other high-risk groups, people who are older, people who are diabetic, people with diabetes, or hypertension, to engage in very stringent social distancing, to practice all the hygiene techniques that we talk about, hand washing, limit contact with people who have high risk of exposure, because what you don't want is those women to put themselves at risk. Here, with COVID-19, as with African American maternal health outcomes in general, we know that there are a number of contributing factors that would lead to greater risk. And one would be high quality care, the one I just harped on for a very long time, missed or delayed diagnoses. And this has become a problem for African American women who are pregnant in this COVID-19 context, because at the beginning of this pandemic, it was very difficult to be tested, even if you had risk factors. And pregnant women have are considered at risk. But unless you had traveled out of the country, had traveled out of the region to a hotspot, had a definitive exposure, were showing the symptoms, particularly with that fever at 104 or greater, it was nearly impossible to get tested, which would lead to delayed diagnosis. But if you are at risk and there's a delay in diagnosis or detection, the rate of severe illness escalates for you. Lack of knowledge among patients and providers around warning signs. People were not as clear of all the signs and symptoms of COVID-19 infection, but that's because health professionals and researchers were not as clear. We've all been learning as we go along, and that has complicated things. And that's particularly problematic in a community where testing was not instituted in any of the North County facilities until midway through this pandemic. Whereas if you lived in not in West or South County or city, there were test sites up and running. In North County and North City, there were not. And by the time those test sites were in place, the spread of the infection was well underway, which is why we have seen higher infection and mortality rates in both areas. I think what's most important about African-American maternal health disparities and COVID health disparities, and then the intersection of these two, is that we know all of this is preventable. Now, the infection itself is not preventable, and the severity of that infection is not preventable, but the disparate rate of spread from COVID-19 would have been better controlled had we had testing availability in this region. And I say that because I sit right in North County right now, when everyone else did. With maternal pregnancy-related mortality, the issue is that we know that 60% or more of these deaths are absolutely preventable. They should not have happened. And so addressing these factors that I keep alluding to and stating is key to ending that reality. We also know that we know very little about the effect of COVID during pregnancy. So what do you do about that? A registry has been established to gather data and follow mothers and infants so that we gain information about the impact of COVID on pregnancy and delivery and maternal health. We do know most infants who are born to mothers who are COVID-19 infected are negative for the virus. So it doesn't seem to easily pass from mother to infant. Because of the mother's, if a mother is infected, the mother and the infant are separated at birth to avoid infection. It's not clear, but right now the assumption is being made based on what's been observed that the virus is not passed in breast milk, and it seems safe for women to breastfeed. There's only been one report that I could find in the literature to date of a miscarriage by a woman where the COVID-19 virus was detected, and that was in the second trimester. But again, that registry will help people to understand and to figure out what is going on in pregnancy, as opposed to us simply counting what comes out in the literature, because not every situation is going to be reported in a journal. It's just too much going on and it's too hard, but that registry will help. In other coronaviruses, SARS and MERS again, women were more likely to have low birth weight babies when infected. And so again, that registry is going to be important in understanding if that is also a consequence of COVID-19. And there has been some reporting of this among women who have been infected with COVID-19, but not to enough or to the extent for anyone to know if this is going to be a substantiated outcome. Now, disparities around maternal mortality from women who are infected with COVID-19 are influenced by those pre-existing conditions that I mentioned for maternal mortality in pregnancy-related mortality in general: hypertension, diabetes, cardiovascular conditions. One I didn't put up there, but it's important: asthma as well. And you have women who have all of these conditions. And again, these are conditions that we know we have higher rates in African-American communities. But it's important to understand that these pre-existing conditions in and of themselves do not happen in a vacuum. And so this graphic is really one we've started to use for a lot of disparities related work. And that's what we see of maternal mortality is just the tip of what is really going on. And we focus on these social determinants of health. I've talked about quality of care. I've talked about where there's access. There wasn't access for testing, but guess what? You've got many fewer resources for maternity care in the very same regions where we were unable to access testing earlier. There's implicit bias. There are intergenerational effects. Even if you manage to acquire higher education, you increase your income. Many of these women were not born into these circumstances, and so they carry the health consequences of growing up in lower income or high poverty environments where we see a higher concentration of environmental exposures, higher rates of air pollution. And we know that air pollution has negative impacts on pregnancy and pregnancy outcomes. So you have the low income women who are currently living in those environments, and then you have higher income, better educated women who spent most of their childhood and adolescence in those environments and carry those consequences with them. We see these socioeconomic barriers, and all of those things come with decreased access to healthy foods and other material goods that we know inform health outcomes. So what can we say, what else can we say about COVID-19 and African-American maternal health? There are structural factors that are impacting African-American maternal health and outcomes: quality health care, poverty, lack of affordable and high quality housing. We know that if a woman has asthma and she's living in a home with that's older, with higher rates of material deterioration, as well as dust mites, roach infestations, mold, that asthma is going to be aggravated. If she becomes pregnant living in those conditions, the aggravation of the asthma, the experience of asthma, as well as other health conditions are exacerbated. The nutrition that's necessary for a healthy pregnancy is more difficult. All of those structural factors are coming into play. Now, what's interesting is that in this region and in many other areas of this country, we live in very segregated environments. And one of the things that people who study segregated environments note is that regardless of income and education of that community, what you often see is a loss of resources that we take for granted in the promotion of health. And those are access to supermarkets and grocery stores where you can get high quality fruits and vegetables, the quality and the ability to sustain parks and infrastructure that promote physical activity. It is not a given that everyone with the same education and income enjoys the same amenities. Even the location of healthcare facilities differs in these highly segregated regions. And I always point out to people, the Midwest contains one of the largest numbers of hyper-segregated urban and suburban communities that we see in this country. And St. Louis is one among those. Other issues that come up because of COVID, though, are patients not seeking care during pregnancy or postpartum for their postpartum concerns, because they're afraid of exposure. And if we had had a more robust testing system in place, people would have fewer concerns and fears about that, because we would have a better sense of the spread and the direction of the disease. Mothers and infants may be released from the hospital earlier than usual, because everyone is concerned about exposure. And we know being in a hospital increases your rate of exposure to any number of things. Hospital access, as I've already said, is more limited in African American communities, and the services are more limited in times of crisis. And so I think I've given you enough to think about as it relates to issues of African American maternal health outcomes, and how all of those existing issues and situations and concerns intersect with concerns related specifically to COVID-19, to produce concern and worry in many quarters that we will see some exacerbation of negative maternal health outcomes, just as we expect to see exacerbation of all of these other health conditions that serve as pre-morbid conditions that influence maternal health outcomes. So with that, I'm going to stop, and I'm going to cease sharing the screen. Okay, there it goes. And let you all come back on and take questions.
Does anyone have any questions for Dr. Thompson? Linda, hold on one sec. 1 second, Linda.
I'm unmuted.
Okay.
What can we do as just regular people to help this situation? What would you suggest?
Well, I think we have to, as a community, have frank conversations about where we invest resources. And I say that because I've been a researcher. I've been discussing these issues. I've been designing interventions for over 30 years now. And so when I have to put slides up, like the first one I put up, where we haven't moved the needle, and I can do that for infant mortality, I do it for diabetes, asthma, and we haven't moved the needle. I have to start asking myself, how far can we get with interventions? Interventions are important, but they're not going to solve the problem. These are policy issues. These are social determinants issues. So what can we do? All of us should advocate for Medicaid expansion. For those women who live in poverty, who are concerned about how they're going to pay for health care prior to a pregnancy, not realizing that not getting good health care and getting any health conditions under control before you're pregnant puts your pregnancy at risk, puts your infant at risk, and puts your maternal health outcomes at risk. But you know the cost of health care, and you know you're uninsured, And so you're at economic risk if you seek that care. We always assume because we have federally qualified health centers that makes it affordable, but there are copays. And depending on your income, you may or may not be able to consistently afford those copays. Plus, you have to pay for your prescriptions. And those costs can be put you out of range depending on your income. And so if we had more comprehensive coverage, people would not be caught in those gaps. Adults who are working can go to the marketplace. In states that run their own marketplace, their fees are often lower, but Missouri doesn't run a marketplace. So you only have the federal marketplace, and there are fewer vendors there. And so costs are higher. So Medicaid expansion would capture some of those people and help us. But we also need to be advocating for policy so that every American can have a healthy adulthood. We also have to do more to educate the public on the CHIP program. I encounter many parents who do not realize that through adolescence, their children can be covered if they meet the economic guidelines and can receive health care. The earlier and the longer we keep young girls in healthcare so that they don't develop or some of these premorbid conditions are addressed and under control prior to their childbearing years, the better the outcomes. So that's the first thing, everyone having access to healthcare. But the other thing is that we have to become as inventive as some other communities are in getting healthy foods to all communities. I like what Metro has done in running the Metro buses that bring fresh produce to northern communities, using their bus stops. They use some of their older buses, and then they use their big Metro stations, and they allow the vendors to sell foods there at a low cost that their riders can grab them, get on their next bus, and go home one trip, not extra trips, reducing costs for them. Those types of innovative solutions are the types of community solutions that can move us forward. And health is what's going to move the needle on this.
Thank you, Dr. Thompson. And just to remind everyone, Medicaid expansion will be on the ballot in Missouri in November. And we are part of the big coalition working on that to get that passed. All indications are is that most people want it, which makes sense because it's a good thing. But we still have to work hard at getting the word out and making sure people know to vote yes on Medicaid expansion in November. That's going to be a big, big bonus. We have a question from Diana Fine, who is actually not able to get on video, but she asks, how can we advocate to not only change healthcare availability, but to also change attitudes? She said your story of knowing about being Rh negative was really impactful and heart-wrenching, and having your doctor ignore that.
We are really working hard to change medical education. Now, that's one thing I can say. In full disclosure, I'm a faculty member at Washington University, so I may be biased, but I work with my colleagues at St. Louis University too. And I think medical schools are starting to realize that they have to do a better job of educating students so that when they're out in practice, the way that they communicate, the way that they interact with communities is different. And so there is a big push now to introduce medical students to some of the health disparities information during their training, to acquaint them with communities of high need so that they understand the problems they face. They become better versed in how to communicate and how to treat and work with and advocate for their patients in these communities. That's going to make a big difference. It is hard to be empathetic and to check your biases when you never interact with and encounter people. And one of the places we expect people to encounter diversity is in higher education. But if that's only, say, at the undergraduate level, and then you run off and you never see anyone different from you in the remainder of your education, or you're not asked to deal with the issues of people who are low income, living in poverty, people who are racially and ethnically different, to understand the expressions of disease in their communities, then you cannot know. And I think there's also been a greater call for those physicians who have that experience and do this work to be mentors to new professionals. Because the other thing that we have learned through research is that those practitioners in almost every field coming out of school mimic the behavior and practice of the people who train them. And so when their mentors are open and are used to working in diverse environments with diverse people, are comfortable with that, show respect, the people that they train follow that pattern. And so really working with the medical professionals who provide the instruction and the mentoring to be those role models.
Karen, go ahead.
Hi, I appreciate greatly what you just shared, because a lot of educational institutions are having their student teachers do practicum in urban and other areas. Is that becoming standard in most medical programs now? Or is it just a few? Because I love what you're saying. Thank you, thank you.
You're welcome. I'm not going to say it's becoming standard, but you are seeing an increasing number of medical schools try to develop what community engagement activities and programs to increase the likelihood that those medical students and residents being trained with them encounter people from diverse backgrounds. Some of the drive for this is because accrediting bodies recognize the importance of this. This is their way of attempting to contribute to the strategies we need to reduce disparities. Funders are stimulating these efforts because they want to see greater progress in this area. And so I see more of it now than I saw 20 years ago, 10 years ago. And I think with this type of push, it's usually, dominoes. Once a few leaders step out, others do. And actually, I have seen some wonderful programs in other communities. I was visiting an institution in Miami, and their program, their practicing physicians actually run a medical clinic that provides year-round services to low-income communities. And then during the medical school year, their students, with the help of the residents, help provide care to the residents of these communities. And those students can follow patients across their medical career. And so the patients don't experience, a student here, a student there, and they get some continuity of care because the physicians are consistent and a student is following them throughout their training. So I'm seeing lots of models, and I'm very hopeful with what I'm seeing.
Elise, if you could please unmute yourself and then you can ask your question.
During COVID, how has access or lack of access to food impacted pregnant women? Because in order to travel, you are exposing yourself to possible risks to access food sources. And is there some sort of community effort? What's the discussion in bringing more grocery stores with healthy foods that are at prices that are experienced all over St. Louis to areas, and maybe with some complementary nutrition programs?
What I will say is you're absolutely right. One, during this period, because of supply chain issues and all of the things that we hear about on the news, costs have risen for food. So that becomes a complicating factor. We have also seen people furloughed, and so people are losing their employment, and that has hit many of these communities harder than other communities. But we have seen good community response. The other complicating factor is in going out to stores. Some people have to use public transportation. That puts you at risk of exposure. In addition to having to go to the grocery store, if you still have the funds and the income to do that. And then finding the PPE and supplies to reduce your risk has been more difficult. It was only probably in the last 3 to 4 weeks that I started to see PPE available in the stores, the mask and gloves again, because early on they disappeared and they did not come back for some time. And so what we saw in response to that is many organizations, Prepare STL is one of them. The Urban League has stepped up in a tremendous way. Some churches have, and actually some municipal governments have been collecting PPE and distributing them free of charge to people who needed to be out to access to go to work, because many people couldn't stop working, and that includes pregnant women. They have to use public transportation because that's how they get to work, and that's how they get the supplies they need. So they've been distributing those in these communities, including masks, gloves, supplies for sanitation, in addition to food supplies, including produce, vegetables, and basic staples. And so from that standpoint, we've had good community response. But we do still see a great deal of need.
Does anyone have any other questions before we let Dr. Thompson go? Well, thank you so much. I think this was incredibly eye-opening. Linda, do you have anything to add before we wrap up? You're muted still.
I just want to say thank you to Dr. Thompson. This was excellent, and I think we all learned quite a bit from your talk, and we appreciate it. Thank you.
Thank you for having me. And if anyone has any questions, if you go to WashU's website, you can find me, and I'm always happy to answer questions. So
thank you again. And for thank you all so much for attending. I know this is kind of our new normal, but I think it's going very well. And I think we all, you know, it's a wonderful way to hear from people in our community. And the more people who join us, the better. So be sure and join us next time. Next month, we are doing our Lunch and Learn with Sayer Johnson from MTUG, which is the Metro Trans Umbrella Group. And I think he's going to talk a lot about trans issues, not only in the Missouri legislature this year, but also maybe during COVID as well. Make sure to sign up for our 5 Ways to Advocate e-blast that goes out every week. Every Monday, you will receive it in your inbox at 9 a.m. You can, if you're not already signed up for that, you can shoot me an email at jbernstein@ncjwstl.org, and I will put you on that list. And then finally, next Thursday, we have our book club that we're doing virtually. And we're reading a book about voting rights, and you can learn more about that in the 5 Ways to Advocate as well. So just shoot me an email if you have any questions. Thank you all so much, and we will be sending out an evaluation. So look for that in your mailbox as well. Take care, everyone. Okay.